All right. Welcome back to another episode of Esoteric Artifacts. This is episode number 8 now. I'm back with Dr. Jared Rivera here visiting us again. Uh, Want to continue some of our discussion from last episode, talking about healthcare in general, but we specifically focused on Medicare, Medicaid, some of the issues with pandemic related policy. We didn't really get into some of the key subjects that we really wanted to talk about, and we wanted to just provide a little bit of clarification and expand on some of that. So, yeah.
I do have to correct you there. I think the more I've gone through my training, the more I don't like being called a like Dr. Jared Rivera. Like I think when you start off your first year, it's like you introduce yourself as Dr. Rivera to everyone that you talk to in the hospital, and then after 2 or 3 years, you start to realize I don't know nearly as much as I need to. I'm not where at a position where I should be, acting like I'm in some position. So I hope that anyone listening does not think that I'm someone that prides myself on being called that.
Well,
So
that's why you let other people introduce you like that. You're
yeah,
not the
that's fair.
pretentious one referring to yourself as Dr. Rivera. But I mean, I do think it's worth it. Like for the sake of this, we
Yeah,
kind of have to like point out that you are credentialed,
yeah,
in
yeah.
in
No, I
this
appreciate
regard.
that.
But yeah, no, I can, though I have no level of education close to yours, I can relate in that if I did have your education level, I would probably feel the same way about
Yes,
it.
yeah, yeah,
And we're surrounded by a lot of doctors, so we
yeah,
we know how very human
yeah.
they are.
Oh yes, yeah, definitely.
Yeah,
And that's something that I think that goes unnoticed is we have doctors in general have to or have kind of been trained to put on this facade that that they know what they're talking about, that they it's for a good reason. You don't want to go see a doctor and then be questioning everything that they say. But that goes to say, this little journey of kind of diving into the healthcare industry in general has kind of been just another thing that's opened my eyes to how little we really know.
absolutely.
Yeah. So and that's been humbling, and
Yeah,
just like any other part of my training, and eventually it gets to a point where you realize that you just need to accept and address those knowledge gaps and try and fix that. But yeah, no one's perfect, and it goes for any profession.
I will say in my experience, and I knowing a lot of physicians, of all walks of life, like young,
Hmm.
very experienced, retired. It's pretty rare to see somebody have that approach and that sentiment that you have, especially so early in your career. There's definitely, I think, people that know doctors well will note that there's a level of God complex that's
Yeah,
going on there with a lot of them, right?
yeah,
And to some degree it's earned because you are literally saving people's lives. Like
hmm,
that's gonna go to your head to some degree, when you are highly valued in society. You're very highly compensated. You spent a long, you were on a long road to get to that point. So of course you want to feel some sense of achievement in having completed that path, and then it's not over, right? You're
hmm,
continuing your education
hmm,
constantly if you're a good doctor, that is. And yeah, at the end of the day, especially certain types of doctors that are real rock stars within their profession, like you really see that God complex and just that
yeah,
complete unwillingness to like approach anything with a humble mindset, I think.
yeah. And that's the biggest downfall for uh, any profession that you become an expert in. An expert is once you think that you've attained all the knowledge that's possible, you stop growing. You start to that's when it becomes dangerous. You can make a bad business decision. You can lead someone down the wrong. If you're a consultant, you can make a bad recommendation.
Hmm.
Uh, and if you're a doctor, that could end up being someone's life. So I think that's important for I think that's an important thing to learn is to have that understanding of, okay, I have the knowledge, I have what I need to do my job, but I'm not perfect and I don't know it all. And that's something that's always been valuable for me is to continue to fill in those knowledge gaps, because you're never gonna have all the information that you need. You're never gonna be at the top, and you should never feel like that. And I think I like that. I like continuing to grow.
That's a really healthy attitude to have, I would say. And like people that are going to persistently drive themselves
Mm-hmm.
further to excellence and never rest on their laurels, like have that mindset. I think probably a lot of like some of the top professional athletes, I would imagine they have that mindset internally at the very least.
Mm-hmm.
If not what they're projecting outwards
Yeah.
for marketing reasons, like internally, they're probably always like, I'm mediocre. I need to get better,
Mm-hmm.
even when they're at the top of the game. And
Mm-hmm.
I share that mindset with you. I think I would could not be content with what I believe is mediocrity. And being one of my own harshest critics, I consistently think what I'm doing is mediocre and needs to be better.
Mm-hmm.
And yeah, there's so much out there to learn. None of us can ever fathom learning a fraction of it within our lifespans.
Mm-hmm.
The mortality, like that's why lifespan is such a serious issue for for humans.
Mm-hmm.
It's
Finite.
we were just talking a few minutes before we started recording. Like, do you think Jeff Bezos, or Elon Musk, like one of the richest men on the earth, would give up every single thing they have if they could get back even 20 years of life?
Mm-hmm.
I think so. I definitely think they
Yeah.
would,
Yeah.
because youth cannot be regained, and like a ton of these billionaires are obsessed with trying to figure out like how they can live for longer. And
Yeah.
I mean, there's some of those guys like I don't remember who he was. He was one of the Rothschilds, though. Part of the banking family. Guy had I think like five hearts put in him. Like by a certain point, it's like obviously like he owned the hospital, he probably owned the wing, like
Yeah.
it donated probably a ton of money to that sort of research as
Sure.
well. But like
Did great things.
also one guy got five hearts at the end of the day.
Yeah. Yeah.
Yeah.
Yeah, and I that's something that I like to do too is kind of pick the brains of the older generation. I've talked to a lot of the people that my attendings who are in charge of training me,
Yeah.
and um,
I'm gonna get him. That fly is
it's like it's not moving.
he's been bothering me
Um,
all day.
but yeah, like kind of asking them, at the end of your career, you're training me coming in, where's your mindset at? Like, what kind of things do you look back at it and wish you would have known from the start?
Hmm.
And actually, very consistently, like multiple of my superiors or my just people that are kind of mentoring me have said that when you get towards the end of your career, you're never gonna look back, or them personally, they never look back and say, I wish I would have picked up that extra shift. I wish I would have done that extra, gotten that extra title or that extra degree, or worked a little harder. Pretty consistently, they say, I wish I would have taken more time off. I wish I would have spent more time with my family, just enjoyed the journey. And a lot of them are well-rounded people. It's not even like they're
Yeah.
crazy in their head and in the clouds. Like, a lot of them are well-rounded, but it's never enough. It's never enough time to enjoy it, enjoy your family, uh, and none of them would ever go back and say, I wish I would have picked up that extra shift, taken that extra
Absolutely
job.
not. And I mean, life is so fleeting. We both know a number of people that have passed away
Hmm.
in this past year and last year as well. Um, just seeing that play out and wondering, just the value of spending that time while you have it,
Hmm.
because it's not always expected. We don't know how life comes at us. I've definitely had my perspective shifted. I had
Hmm.
a near death experience a few years ago, like a very serious car accident, and yeah, since then I'd say I live fundamentally differently now. I try to take each day, to its fullest, and sometimes we get caught up still, but you definitely try to make the most out of your time, out of your relationships,
Hmm.
and yeah, I think what you're saying is important.
Hmm. And I mean, you can look at that as a huge blessing for you in your life. I mean, not many people get that wake up call. I mean, a lot of
Yeah,
people.
for to have such a near death experience at a young age, like I actually consider it a privilege. A lot of people might look at me like I'm crazy, but I
Mhm.
say it's one of the best things, if not the best thing that ever happened to me, because of how much it transformed my life.
Yeah, yeah,
Yeah. But with physicians, especially, you have these type A personalities, right? That a lot of them, especially these days, you see a lot of them. They're not getting into it primarily because it isn't necessarily their passion. It is a very high paying profession, and it is a
hmm
means to early retirement for a lot of people, right?
hmm
So a lot of them are just so on this path of like, how much money do I need to have banked to be able to like just take life easy?
yeah,
And especially because it's a high stress lifestyle, man. We've
yeah,
seen how much burnout has happened in nursing, in
yeah,
physicians, and as they one thing I've noticed is they've really been expanding the role of nurses, nurse practitioners, physicians assistants.
hmm
um, do you think that we could even see like an environment potentially where physicians are starting to be replaced in
mm.
that?
Uh, ooh, that's a tough one. Uh, it's definitely we're definitely feeling that kind of pressure. And I guess I'll start off answering that by saying I think anyone that goes into any sort of healthcare, I would give them the benefit of the doubt because I think the majority of people, whether it's a physician, whether it's a nurse, whether it's a nurse aide, even down to the to the level of someone who's just in charge of keeping an eye on a patient, just the person who helps feed the patient, like anyone who goes into that profession, especially nurses, the majority of them are really going into it for the passion of taking care of people. And I think that when you see someone that says that in middle school or high school, I'm thinking about going into nursing or medicine. Um, the majority of them are actually good intentioned people that have a heart for caring for people. So
Hmm.
that for the most part, are people that are in an area where, or in a mindset or a calling of doing something good. Um, so that being said, um, in regards to physicians with nurse practitioners, physician assistants, we are seeing a lot of kind of a transition to they're called advanced practitioners or kind of APPs is what we call them. But um, we are seeing a lot because it is cheaper for them to be hired.
Yeah,
They, for the most part, they get more experience practicing than we do prior to being on their own. And
and the
they're
cost to train them is lower too,
it is
right?
so much. Yeah,
Yeah,
they go to less school. They kind of get to skip out on a lot of the pathophysiology and just all the book knowledge that we have to get forced into our heads,
yeah,
which is a good thing and a bad thing. It's cheaper. It's a shorter time period. On the negative side, sometimes things aren't so textbook, and that's where
yeah.
things can get a little sticky. But we are seeing a lot of replacements of positions that are opening because hospitals, clinics are realizing that they can do pretty much everything that we can, and it's cheaper, and why not? So my experience with them has always been very collaborative, where we all know our own boundaries. We know that the ones that I've seen have been very good at understanding like when they can take care of something and when it needs to be escalated to someone else. But yeah, definitely, it's going to start, little by little, taking over more of those positions. One thing that I was talking to one of my attendings about, though, in regards to that
Hmm.
is um, CMS, which is kind of the Medicare Medicaid system.
Yeah.
They have just within this last month have kind of made a new rule where a hospital can bill for 80% of a service if a nurse practitioner sees them, um, but if they want 100% of the service, they have to have a physician that's supervising them also see the patient and complete more than 50% of the documentation. So every day, the NP will kind of take care of them, do all the heavy lifting work, but a physician still has to sign off on them. And it's kind of interesting because, that comes down to, if you think about it, 80% of a $500 hospital day um, versus 400. Okay, it's not going to be that big of a deal. But if
Yeah.
you multiply that out for a 300 patient bed, it does add up. So hospitals are kind of weighing out the pros and cons if it's really worth it. So there are hoops to jump through there.
Well, so I would imagine they probably are having, one physician overseeing the operations of multiple nurse practitioners in that
Yeah,
case.
yeah,
Yeah. So, I mean, it seems like in that type of setup, doctors are essentially just becoming like management of sorts.
yeah.
That's interesting because I appreciate hearing your perspective on this because I look at it just from a business perspective, especially with how much
Hmm.
private equity has purchased hospital systems over the last decade, especially. Those guys, they're money guys, they're numbers guys. They're
Hmm.
gonna look at everything by the numbers, and they're gonna aim to attain optimal efficiency in those numbers.
Hmm.
And if I was making those decisions under the premises that they are, I would say, yeah, absolutely. If nurse practitioners can now prescribe, can now do all of these things,
Hmm.
like let's go nuts. Like let's keep a few physicians on staff. Like let's keep obviously top surgeons on staff for our
Yeah.
reputation's sake. But for the most part, like I would assume if I don't even know what the full difference in wage is. So I just know that it's not that close
Right.
um, in terms of compensation packages. But yeah,
But yeah, and I thought the reason I was talking about that with my tending is kind of, it is interesting how this CMS kind of dictates. They like to make amendments and they like to make these new things to. In their defense, they're probably trying to keep costs low, but it's kind of like an arms race. We're constantly trying, not us, but administrators are constantly trying to meet these demands so that way they can continue to bill. And so that's why we were talking about that. And I thought that was interesting, but
yeah, this kind of stuff doesn't need to go through any legislation
no.
either. Like this is just executive bureaucracy
Hmm.
essentially. And what's interesting is that Medicare reimbursement is so low that I'm surprised hospitals even care particularly about this. Because if hospitals had to operate exclusively off Medicare, Medicaid reimbursements, n- pretty much none of these hospitals would be in business.
Yeah.
Private insurance is paying their bills right
Yeah.
now.
Yeah. And that was one of the things that I kind of wanted to clarify on. I think I generalized a lot of what I was saying about billing for a patient. When it comes to after the Affordable Care Act,
The
um,
capitation,
capitation, fee for service, the kind of two ends of the spectrum.
yeah,
Affordable Care Act kind of brought in bundled fee for service. So it's right in between the two. And basically, they're paying, if you get admitted to the hospital and you have uh, you come in for a heart attack. Okay, we know how much this usually costs, so we're gonna pay you this much, regardless of how many labs you order, regardless of how long they're there,
yeah.
blah blah blah. So
Well, so that's probably good. That's kind of a good thing,
right,
right?
it sounds great in theory. Same with in the office. If you come in and you're taking care of someone who has asthma, okay, we're gonna pay you a set amount because we know that most people that have asthma cost this much. So here you go, like regardless of what you do. So it eliminated the need for extra, not the need, but it eliminated the drive for physicians to
The bad
just order.
incentives,
Yeah,
yeah,
it made people think, okay, do we really need to order this extra chest X-ray, or because at the end of the day, is it really going to change anything? And no one's really financially profiting from it. So definitely a good, it was a good move. Now, and behind the scenes, the things that a lot like physicians in general, we don't really ever experience unless you investigate it on your own. And something that I've been trying to understand, and it's just so hard to understand, is the negotiations that come with that. So, um, sure, someone can say, I'm going to pay you a set amount. Who gets to decide that price? So the insurance company makes a deal with the hospital, um,
hmm
and kind of decides, what do you think that the insurance company will say, like, oh, we can. we can pay you this much for a fee. The hospital saying, well, we think that's going to cost a little bit more, blah blah blah. So there's kind of a back and forth. And something that has been interesting is just why are these healthcare costs just continually going up? It's not that people are costing more money because, if anything, our advancements have made it less expensive. We shouldn't be needing extra tests, and because we've gotten to a point where we can treat people a little bit easier. So why are over the last 20 years, and we can show you a chart about this, just the exponential increase, way beyond inflation, way beyond any other industry in America. Why is this continuing to go up? And that's something that I really think came with the uh,
Yeah, it
like
was well,
the
we talked about that, and if you're watching on YouTube, I'm gonna have that chart pulled up here. But essentially, so I think that's a two-step problem. That's it's tied to education and it's tied to the medical loss ratio, which
yeah
was part
the
of the
medical
Affordable
loss.
Care
Yeah.
Act. Yeah, the medical loss ratio was one major point that we wanted to talk about in the last episode that we didn't get an opportunity to.
Hmm.
But essentially, what it did was it capped percentage of profits for insurers,
Hmm.
which meant that it really changed the incentives for insurers. And I know people generally hate insurers. People have a lot bigger problem with the insurance companies than they do with their providers or with the actual hospitals or with the private equity firms that most people are not aware own the hospitals. The insurers are an easy group to vilify,
Hmm.
and they're deserving of some of that. Don't get me wrong,
Hmm.
especially because of how much money they spend lobbying. People see that, like if you go on opensecrets.com or .org or whatever it is, and you look at like who are the largest, which organ industries spend the most money on lobbying. Well, you'll see defense. Obviously,
Yeah.
it's going to be number one. Number two, I'm pretty sure actually is the insurance and pharmaceuticals.
Hmm.
Uh, are, are,
Yeah.
are all up there, and so people are disgusted by those industries because they see that. But um, essentially what happened was, and a lot of people said this about the Affordable Care Act, was that it was a handout to the insurers. And a lot of people didn't understand why at the time because they were like, well, like it's actually capping insurers' profits at 20% of the total spend. Like, so they have to refund like premiums if they don't hit that
Yeah.
medical loss
80
ratio.
80% of the money that comes in needs to
Yes,
go
has to
towards
be spent
paying
on
medical
actual
bills.
care.
Yeah.
Yes.
Which again
Yeah.
sounds like a good
Yeah, I mean,
intention thing.
I mean that sounds totally reasonable because a 20% margin for a company is quite high.
Hmm.
Like there are very few industries that enjoy a 20% margin.
Hmm.
Like telecom typically enjoys the highest margin, and that's because it's virtual oligopoly. You have AT&T, you have Verizon, you have Sprint, you have
Hmm.
T-Mobile, right?
Hmm.
Like in the country. So those companies have historically enjoyed like a roughly a 15% profit margin, and that's considered very high year over year.
Hmm.
Like you might have certain years as a company, like let's say you just innovated, you just created a new product, you managed to scale efficiently, didn't cost you a ton of money in debt, and you're like first 1 year you see like 60% profits. Like yeah, that could happen, but consistently to see that is not very common. Though
Yeah.
I will say the last 2 years we have seen some very very high profits in the aftermath of the pandemic,
Mm.
especially for a lot of tech firms, a lot of firms that cut costs drastically, like
Mm.
expenses that they were figuring in, like office space and all this stuff that remote work facilitated lower costs for them. But with insurers, they so that like it seemed reasonable to be like, oh, okay, you just can't take more than a 20% profit margin. But when you insurance is also kind of an oligopoly. Like there are small insurers, but really you have United Healthcare, you have Humana, you have Anthem, you have
Mhm.
like a few big players in the United States healthcare marketplace, right? And
Mhm.
these are the people that made Marketplace Affordable Care Act compliant plans.
Mhm.
So there were still, small HMOs that were for like employer-based programs, but for everybody that had to get their healthcare through the open marketplace, they were using one of these giants.
Yeah.
And these giants, they now had incentive because they're already spending tens to hundreds of millions of dollars lobbying Congress.
Mm.
They now had incentive to work with the hospitals on raising the total spend
Yeah.
because yeah, like you were
Yeah.
saying,
And again, to avoid vilifying the insurance companies,
they're an
they
easy
are
target.
they're an
Yeah,
easy
yeah.
target. They are a business. So if you think about it, if you're capped at a 20% profit and you're a business, and every business wants to increase, their profits. How are we going to do that? Well, the best way to do that is to not fight these higher costs. So the hospital says, well, we think that this hospital stay is worth 900 instead of 800. Why would they fight back against that? Because if they're paying out more, then that gives them the allows them to have a higher total
Total profit. Yeah.
total profit, so that 20% can
Yeah.
grow. And year after year, it might be a little bit here and there, or it may not even be intentional, but any business has that mindset. And so I'm not going to sit here and say that it's all intentional and that they knew that this was going to happen, but indirectly, that's little by little starts to push up the cost because you're going to accept a higher rate of something that they know the blue market value is way less than what they're asking for. But next year they'll be able to get that 20% will be a little bit more than it was. So
Yeah, and
it's a business
who's
model.
paying the costs of this?
And
It's the consumer of
yeah,
the service. It's being passed off in the form of premiums.
yeah,
So that's us. We're paying those
mm,
costs, not and to some degree the government as well, but that's the taxpayer by
mm,
extension.
yeah. So it's a little sticky, and it gets to a point where uh, it grows proportionally out of where, more than it should. Now, in going with that, something that I've kind of had a lot of conversations about, that's can be very controversial is, okay, so why not go to a single payer system? Wouldn't that eliminate this? It would make it more transparent. We can just get rid of all these games. There's not going to be all these different payers and different insurers that are getting different kinds of payments because by the way, one insurance company might pay a certain amount for if you go to a certain hospital, but if you have another employer and you go to another hospital, it could be two times as much, three times as much. Again, because those are being
Yeah, they're
set
negotiating individual contracts.
individual.
These are
Yeah.
very nuanced deals, and I mean, a lot of it is like within networks,
Hmm.
network coverage. So you may not even be able to go to a certain hospital if you're
Right.
with one provider.
Which is crazy. So again, that's where the temptation comes in of let's go to a single payer system. Let's go to universal healthcare.
Yeah,
Let's do what Canada does. And I can agree and I can disagree, and I can lay out the pros and cons of that. And I'm not going to sit here and tell you what the right answer is because I don't know myself. But if we were to go to a single payer system, it would definitely eliminate all these games, and it would make it in the short term. It would definitely bring down the cost of healthcare, because those prices would be set and there would be no variability. Um, first, the first con that I will say is if you go ask someone in Canada or in Europe that has universal healthcare, how is your? I'm sure they're happy with their cost, and they're paying a lot less. But if you ask them, how long do you wait for an MRI? If you go and tear your ACL, how long do you wait to go see a specialist? How long, anything? It's months. A lot of them are
hmm
just on the waiting list because they can't get in. And I've heard of people in Canada that will actually drive down to New York and pay out of pocket for something that they need because they can't get in. So it comes with it comes with some
yeah,
costs.
absolutely.
So it's not, you're getting some benefit, and it's going to come with some negatives. The other thing is, I think if you look historically at kind of any government run system, in the short term, like I said, it may drastically reduce the prices, but over time, what's to stop the government from kind of skimping and kind of pushing a little bit more? And we want to make a little bit more profits. So I think long term, and of course, that's all hypothetical. I'm not here to say that that's not the answer. I think it could help, but you have to also be very aware of what you're accepting with that.
Yeah, I'm actually pretty in favor of a single payer system, but the way I would structure that is probably a little bit differently than a lot of people would. I believe that I think more of a actually in a way it's more of a Medicare model,
Mm,
like where you have the single payer system that everyone buys into, that really only covers the most essential of care.
mm,
So I'm talking like life saving procedures, like acute trauma care, like that kind of stuff. You have a system that is that pays for that universally. However, there's a lot of controversy around a lot of operations that people you know, uh, agree or disagree on.
Mm.
Like you have very controversial things when it comes to gender clinics, when it comes to abortion, when it comes to a number of subjects. There is no way you're going to get the entire country of the United States on the same page with
Mm.
whether one of those things should be covered by insurance or not.
Mm.
Therefore, I think that the private market should offer supplemental plans, the
Mm.
same as for Medicare.
Interesting.
Um, that's how I would structure it. And this is a product of years of discussion with insurance agents during my time in that sector and with physicians and whatnot. I think that's the most amicable solution.
I don't.
However, that would not be favorable to physicians, to providers. Like wages would go down unequivocally.
Mm.
I think, and yes, like you mentioned, there would be some disruptions in service. There would be some increased wait times still. Even with that, with
Mm.
because like we've talked about, part of the reason why we have those things so good, at least here in the United States, is because private insurance pays so much
Yeah.
compared to Medicare, Medicaid.
Yeah.
So if you have the government becoming the single payer, it's you can't expect it to be much better, if at all better than Medicare, Medicaid currently is. So hospitals and clinics will be forced to scale back a lot on their expenses, and some of that is actually much needed.
Yes. Yeah.
Anybody who knows anything about hospital procurement will tell you that the people that are in charge of that are decision makers, they're not the most savvy purchasers. Either
Mm.
that or they're giving out handouts to their friends. I'm not sure,
Mm.
but they are. I've heard stories of hospitals paying like 5 times market price for PPE or for like various other things that are disposables and consumables. It's like for me as somebody, I sell medical devices actually in some capacity. Like that's one of our products is a device that is used within hospitals. It's a very high margin product, and so like if you're a business person and you sell these types of products, you see dollar signs
Yeah. Yeah.
because they don't care because there's so much money within the system.
Yeah.
That would all of that excess fat would have to be cut out
Yeah.
if you wanted to effectively implement a single payer system. But that's really not even touching on our entire pharmaceuticals problem.
Oh yeah.
Like
Oh
that's
gosh.
a whole nother beast. And I don't even
I
think
did.
we want to get into that right now.
Yeah. I don't want to get into it too much.
Yeah.
Again, we're not. I'm not saying that there's one issue. You're not going to
Yeah.
vilify one, but I think they definitely get a bad rep.
Yeah,
But
I mean they I would argue deserve it more than insurance company because
yeah.
insurance companies, they're profiteering. They're making some people's lives
Mm.
difficult and challenging. I would argue their negligence is not literally killing people. Purdue Pharmaceutical, the creators of OxyContin, were sued into bankruptcy. But at the end of the day, the Sackler family's personal assets were not touched. They were deemed protected by the federal governments because they didn't pierce the corporate veil. They didn't, you know, like you want that to be the case for a lot of reasons, but not when someone is doing something as shady as creating mass painkiller addictions in a country
Right.
and lying to doctors, lying in their marketing
Oh yeah.
material. Like the Sackler family should be broke and completely, devastated financially.
Mhm.
Yet they are still multimillionaires.
Yeah.
They're
They
they're
they
hi- they're probably laying low. They're not like socialites or anything. You don't
yeah.
hear what these people are doing, but they're sitting around with millions of dollars
Yeah.
still.
They got caught, but they didn't piss off the wrong person enough.
Yeah, yeah, and that's actually really funny that you just said that because I just thought about Martin Shkreli. Do you remember that guy,
Uh-uh.
Pharma Bro, from a few years ago? So
Uh-uh.
okay, so Martin Shkreli, young guy, brilliant investor actually, made a ton of money as a running a hedge fund actually. Like by the time he was in his early 30s, he was buying biotech companies, and I think it must have been around it was around 2015 2016 that this all went down. He came into the public eye. He bought a company. The drug was Daraprim.
Okay.
So it's I don't even know what the drug is for, but it's for a rare, very rare condition. It's not a particularly life-saving drug,
Uh-huh.
like, but it is, and there is a generic option, I believe, as well.
Uh-huh.
But he raised the price like 700% or something like that, and he got like all of this media attention on him, and people like he was just public enemy number one, and it was hilarious because I mean more things happened. This is the guy who bought the Wu-Tang album, by the way.
Oh,
You might
okay.
remember him more for that.
Yeah.
But I mean, he actually just got out of prison, which is
Wow.
kind of hilarious. Like he served 7 years. Um, for and actually he wasn't even prosecuted for the pharmaceutical thing because there was no crime there. Like he just raised the price. People didn't like him for that,
Yeah.
but they actually prosecuted him for securities fraud, I believe. And what's
Uh,
even more hilarious about that is that so he technically did like violate laws. Like I mean that's clear, but no one was actually damaged by his violation
mm,
of these laws. Like what he did was he lost some investor money, and then he, without telling them, he made money elsewhere, and then he paid back his
yeah,
investors.
Ponzi scheme.
So that's a Ponzi scheme, except a Ponzi scheme, the investors actually lose because the investor like keeps losing the money
Yeah.
over and over again, and at the end there's no money. In this case, this guy, his investors actually made like some of them made like 3 to 5 times their money
Oh,
back, and they still sued him, which is like imagine like some guy made you more money than you expected him to, but you sued
yeah.
him.
Oh man.
Um,
So what he probably was I think that's a
yeah.
pharmacy benefit manager. And that's something
Well,
else.
he owned the
He
pharmaceutical
owned it.
company.
Okay.
Yeah,
Okay.
yeah. He
So
was the CEO.
yeah, with the pharmaceuticals, one thing that I've learned is pharmacy
Yeah.
benefit manager, which is just a whole nother evil, or not evil. I'm sorry, a whole nother beast in the
Yeah,
system.
yeah. I mean, you're not calling them evil. You're saying the very
Yeah,
existence of such a role perhaps is evil
yeah,
in a way. I
and
see what you're
yeah,
saying. I would
naturally,
agree. Yeah,
naturally, things can go wrong with it. So what they do is they kind of make a deal with your employer,
yeah,
and they say, we want these medications to be on formulary. So if your patient, if your employee needs to come in for hypertension, we
when you
are
say formulary, you mean like some sort of schedule?
it's their preferred drug, so
Oh,
they
okay.
can make decisions on um, what they prefer. So they make a deal with the pharmaceutical company, then they make a deal with the employer or whoever is hiring them,
Hmm.
and somehow they come to an agreement, and they're the ones that kind of make a deal, and they try to do it in bulk. So they say, if we use this medication, and if you use this, go our route, we're going to give you a 50% discount, whatever. And it sounds good. The employer on their end, they don't really know. It's not their fault. It's not their job to know what are the indicated medication you should use. What's the like what is the equivalent to this? What's the generic form of this? What's the dosing schedule? Blah blah blah. Those are things that they don't even need to know. So they just say, "Oh, I'm getting a discount and I'm treating this person's hypertension." So sure,
It's just such a pointless like role to begin. Like you have no business creating that kind of like perverse incentive
yeah.
within an area that is like you're talking about like in many cases life saving drugs.
Yeah. And in medicine with medications, it is not cut and dry. There's no equation that you can use to say if the person has this, we need to use this because every person has different like other conditions that are involved. They all react differently to different drugs. And what that does is it puts the physician in a corner because we can't even get the medication that we think we want to use covered. We have to use their formulary for that insurance. And of course, none of us have the time to like sit there and even know all that. But that goes to say like that, that's not the employer's fault. That's all they can see is, oh, I'm getting this bill at the end of the month, and I don't know, like I'm paying for this 200 medications, and how would I know that there's a better alternative, a cheaper alternative? So that's something that's very unfortunate. That it's another middleman that's in there, kind of
Hmm.
skewing it, again, it's different in every insurance company, so it makes it even more complicated.
Yeah, that's interesting. Yeah, I completely had forgotten pharmacy benefit managers even existed until you reminded me of the horror of
Yeah, it's
such a thing.
crazy.
But so the reason I brought up Martin Shkreli though is because it's funny, like you mentioned, like pissing off the wrong people.
Hmm.
Basically, he did that because he pissed off rich people whose
Mm.
money he didn't even lose, by the way. But they just, I guess they felt betrayed in some way by the fact that he still did do something fraudulent there.
Right,
Like he
right.
lost their money, didn't tell them, and then made money elsewhere and like paid them back basically. But like he was prosecuted, and he was the only person ever prosecuted under some of these statutes because like and he was also a prolific internet troll. Like he actually he was out on bail and like he was running live streams. But so like he was running live streams and it was interesting because nobody really wanted to hear what he had to say. Like a ton of news articles came out about him saying
Mm.
like this is this is the face of evil, like raises prices on like some life-saving drug.
Mm-hmm.
And but the reality was is that he was claiming, and I think this has been validated at this point, that if anybody, I know this to be the case because I know that some of the like even the large pharmaceutical companies will do this. If a patient does not have insurance or their insurance does not cover a life-saving drug, they will basically give the drug away. Like I dealt with when I had to deal with Medicare Part D, and that was one thing I wanted to ask
Mm.
you about because Part D is structured kind of similar to like the way these pharmacy benefit managers do. Like there's various schedules or tiers of drugs,
Right.
and like drugs fall into a certain tier, and whether the government or whether your Part D plan will pay for that tier or not is something that you have to like plan ahead when each year when you enroll in your Part D plan.
Okay.
So it's a complete mess. Like you can imagine with the sheer number of drugs out there, selecting a Part D plan is like you have to have somebody plug in all of your medications. And if you're somebody, say you're 75 years old, you're on like a number of medications for a
Yeah.
lot of conditions, like it's quite a bit of work to, collate all this data
Yeah.
and figure out like, oh, is this like actually a decent plan
So I'm
because of
sorry
this
that
arbitrary tier system.
so the tiers are it's not based on whether it's life saving, it's based on what they
It's based on the
prefer.
price largely. So
Oh,
certain brand name drugs
I
will be
never
like
knew
tier
that.
3, tier 4, like generics will be like tier 1, tier 2. Yeah, it's pretty crazy.
And tier one, two is what they would prefer to pay. Like that's what they
Yes, yes.
okay.
So like you'll find more plans that will pay for
Mm,
like virtually all tier 1 and tier 2 drugs, but like finding ones that pay for your specific tier 3 and tier 4 drugs is
wow.
harder. But so I had a patient, or not a patient, a client, sorry. You keep saying patient. I do not have patience. I had a client who, this was the wife of a truck driver. She was enrolled in. She did not work. She was a stay-at-home mom. She was enrolled in Medicare, Part B and Part D, and she had a particular condition that required a drug that there was a generic option for.
Mm-hmm.
However, she was having like some adverse effects from this
Mm-hmm.
generic drug, which is otherwise a great drug, highly effective for most people in this scenario,
Right.
but she just really needed this brand name version of the drug. Now,
Yep.
this brand name version of the drug costed would have been out of pocket if, without Part D, like I believe $5,000 a month, roughly in cost. Um, we just reached out to, it was GlaxoSmithKline, GSK, who manufactured the drug. We just reached out to them and
Yeah.
asked them, went through a very easy process,
Mm-hmm.
frankly, and they just gave her the drug for free.
Mm-hmm.
Guaranteed her supply of the drug for free. And this
Yeah.
was what Martin Shkreli was doing, what his pharmaceutical company was doing as well. But he was vilified by the media so much that because they just wanted to paint a target on the guy's back, in my opinion. I mean, he was a troll, and he,
So
like I said,
he was raising the prices so high, but
so what he claimed he raised the prices for was because this was a drug of low interest. It had been around for a long time. This company still held the patent on this drug, but they were selling it for like something like $5 a pill or something, and he
uh,
raised it to like $700 a pill,
uh-huh.
like a absurd increase. But what he claims was that there's no way to fund research on developing a new
Oh,
and better
yeah.
drug for this unless you do something
Yeah.
like that. And like he said, what he said, and I believe this has been verified at this point. He If anybody needed the drug, he would give, and they couldn't afford it, he would
Mm-hmm.
give it to them.
Mm-hmm.
His company would give it to them, and
Yeah.
that is my experience. I have seen large
Yeah.
pharmaceutical companies do that, so I could believe that that was the case for him as well. But it's just absolutely funny. I heard him do. He did it. He's still on probation and still under like weird like legal limbo. So he's not been able to leave his apartment, but he did a did a podcast. Ryan Long, a comedian in New York, a Canadian guy, a comedian in New York,
Okay.
had him on his podcast, The Boys Cast, and he's got some stories from prison. Owning the Wu Tang album probably helped him out a little bit, I think.
That's hilarious.
But yeah, just all around, like you say, like that's a practice that occurs in the pharmaceutical
Oh yeah.
industry every single day,
Oh
and you
yeah.
don't see anybody prosecuted for it or vilified by the press for it.
It was
But
just he pissed off the wrong
yeah,
people.
yeah, yeah, exactly.
Oh yeah, it's crazy how much that's happening. And I've heard that argument that you know, a lot of people say, "Oh, these companies are allowed to overcharge because it's backing up the research that they're doing and America is the cutting edge of this research," which it's really not, but
Well, I mean, most of the good research really is outsourced to the public sector, right?
yeah.
Universities,
Yeah.
do a lot of that research. But
Yeah. That's something I struggle with. When they have a patent, I can understand not marking it up, hundreds of dollars more, but they deserve to have a period of time where they can make up the profits from what they had put in.
mhm.
That's fair. I don't know how you
Well,
can
because
regulate
I mean,
that, but
even just going through the process of FDA regulatory approval is so
oh
costly
yeah.
and cumbersome,
Well, yeah,
right?
that's part of the problem too. I mean,
Yeah.
why are we putting all these extra regulatory? I understand why. I mean, it's for safety, but do
Yeah,
we
safety
really?
is important, but why can't the government be just a little bit more
Yeah,
accommodating, you
yeah.
know?
That's probably where the bottle. It's basically a bottleneck. It
Yeah.
is, but one thing I wanted to at least make sure people are aware of is it is interesting when you look at someone that's getting and we'll move on from pharmaceuticals after this because it's at the end of the day I don't think we're gonna get to the bottom of that.
No.
But so when a pharmaceutical company um, is when the insurer is charging the employer and when they're making that decision on how much a medication is going to cost, it's interesting because they can sit there and say, okay, this drug is $5. We know this is $5 per pill. Um, so what we're going to do is we're going to give it to the patient for a copay of $3 a pill, and then they go and turn around and charge the employer or whoever is in charge. Okay, we're going to ask you to pay $50 per pill for this because, but if you buy it in a group discount, we'll give it to you for $20 a pill. And again, the employer doesn't even know what this medication is. They don't even know how much it really costs. They just say, oh, look, I got a discount. So sure. And sometimes depending on like what your employer is or what kind of deal they have, they'll charge you a $6 copay for a $5 pill. You're paying more than what it costs, plus they're charging your employer. So one thing that's I've been pushing for all my patients to do anytime that I can tell that they're struggling financially, or just in general, is to use GoodRx, because it's crazy how often, even if you have insurance and you're doing everything right, if you go and buy it through GoodRx at a wholesale price, you will pay out of pocket. Without your insurance, it'll be cheaper, which is just it's transparent to show that this is all a robbery. That the pricing is just crazy. So GoodRx is probably one of the most important things that I think people need to know about. The other one is, I don't know how you feel about this, but Mark Cuban's pharmacy uh, has actually been life saving. It's
I don't know much about it, but I've been hearing positive
Yeah.
things about it.
Yeah, I've had some patients that need things that, I mean, ultimately are like life essential medications, and they can't afford it. First of all, I would go to the manufacturer. Most of them have financial assistance
Yeah, they have
programs.
forms that you can fill
Yeah,
out like straight on
it's very easy to
like
do.
Pfizer, GSK,
All
like
the big
Abbott,
ones.
all of these big
Yep.
companies. Yeah.
And they're very easy to do. But if you can't get it there, it's costplusdrugs.com. So that's
Yeah, okay,
yeah.
I've heard of it. Yeah.
So either GoodRx or Mark Cuban's pharmacy, Cost Plus Drugs. Insulin is the big one that I've heard. He has kind of changed the whole game. And when I first heard about it, I was like, oh, great. Here's another someone who doesn't know what they're doing getting involved. But he's saved a lot of people and a lot of money.
Well, I mean, somebody needed to do that with insulin, especially. I mean, we've talked about how there's poor incentives. Perhaps last episode we talked a lot about how obviously the best outcome is for the patient
Yeah.
to take improve their lifestyle habits and solve this problem
Yeah.
like from the root cause rather than rely on insulin for the rest of their life. But at the end of the day, some people need insulin, and it
Hmm.
is essential for them to continue living. And yeah, that's a big one. EpiPens is another interesting one
Yeah.
that you see. Business people are creative. Like, you got to hand it to them. So Senator Joe Manchin of West Virginia,
Hmm.
his daughter actually uh, is an executive at a pharmaceutical company that recently secured a contract with, I don't know if it was with the state or with certain state institutions, but it was essentially what they did was they reduced the price of the EpiPen, and like so they were able to like bid under like whatever previous contract was in place, but they added a parameter that EpiPens would only be sold in pairs. So, like, how devious is that?
Wow.
So they're doubling the sale, and that EpiPens are not, in certain environments they need to be there legally,
Um,
for safety reasons, but they're not necessarily getting used, and they're only, I don't know what the shelf life is on
it's
them.
like a year.
Yeah, yeah, yeah. So like they're just guaranteeing, they're like doubling their sales effectively, even though, but they're taking a little bit less of a
I've always
margin.
wondered why they came. Like a lot of them
Yeah.
come in pairs.
Yeah, yeah. So I didn't know that was common practice, but I guess like I know that Senator Joe Manchin's daughter was like she was, it was highly publicized, the fact that she did this, and like how dirty of a move that, especially
So
like
how did she benefit from that?
she's an executive at this company. Yeah.
Well, yeah. I mean, most EpiPens come in pairs, and I never
Yeah.
knew why.
Yeah.
That's crazy.
Yeah.
Because yeah, I mean, you're not always gonna need. Most likely, you're not gonna need that in a year. Hopefully, you don't. But
Yeah.
you're gonna want your kid to have that on them all the
Well, and
time.
I imagine the lead time is not that high, right? Like you can probably get that at a pharmacy fairly easily. Like it's
Yeah.
not going to take you weeks to restock if you consumed the one that you had on hand, right?
Right. Right. Yeah. There's no reason for
Yeah.
you. There's some reason.
I mean, maybe
But yeah,
theoretically
yeah,
you have a little bit of like a gap of like risk time there,
yeah,
but
yeah. But if you need to, then your doctor can prescribe you to. There's no
yeah.
need for it to always come in a pair. But all
Hmm.
that's doing is going to waste, and all those get thrown away year after year. It's crazy.
Yeah, well, if you're talking about individuals, especially like not even like, the on-site EpiPen at a gym or at like,
Oh yeah, yeah,
some place like that.
yeah.
Um,
I've never even thought of that.
that's what I'm talking about, is like places that are like legally obligated to have one on hand.
Oh,
Now has to have two
mm.
on hand, I guess. Um, yeah, it's funny, but I'm glad you talked about like good options for being able to like find savvy. Like it's unfortunate that it is this way, but we really have to be savvy in how we navigate the
Mhm.
healthcare environment here in the United States.
Yeah.
And I've had to learn that the hard way, just being uninsured for so much of my 20s, and it's not that big of a concern, but I've had some pretty catastrophic incidents.
Yeah.
Like I mentioned earlier, earlier in this episode, like I had a near death experience in a car crash
Mhm.
just a few years ago, and that's the kind of thing that will financially ruin a lot of people in this country. But I already knew how to navigate this system
Mhm.
because like it's kind of it's more, it's applicable in a broader sense to our society, because debt is very easy to deal with in the United States, actually. Not a lot of people are aware of that, but this country, a big reason business is so prosperous here is because as a business person, you can take on a ton of risk. You can take, loans, however you acquire your funding,
Mhm.
you can take on all this risk. You can fail. You can essentially eliminate this debt because it's not tied to your person.
Mhm.
It's tied to an entity. In most
Mhm.
cases, the entity is defunct, debt's gone. The
Mhm.
money can't be recovered if there's no money there. And then within a few years, you can be back at it again.
Yeah.
Like it's very easy to recover. And it's the same thing when it comes to debt collections. People are not aware of what numbers a collections agency is actually willing to accept. Because the first offers they make you, you're going to be stressed out. Your credit is getting hurt. You're afraid that you're not going to be able to pay your bills. Like let's say, you were uninsured and you had an incident at a hospital costing $20,000. Not an absurd price, actually,
No.
like kind of a low price for a hospital stay.
That's an ER visit.
Yeah, that's like an ER visit, maybe being admitted for one day.
Mhm.
Like that cost. So when you get that bill, that $20,000 bill in the mail, and you were like losing your mind, you're like, that's like half of what I make in a year.
Mhm.
How am I ever going to pay this and like put food on the table? Um, for the first option they'll try to give you is they'll try to say, well, you can you can just do it on a payment plan.
Mhm.
If you kind of ignore these calls for a payment plan, like the hospital, it's going to leave the hospital's hands. It's going to get sent to a collections agency. This collections agency is, not affiliated with the hospital, other than that they are essentially buying the debt from the hospital.
Mhm.
And you have to know the numbers that they're buying the debt for. If you know those numbers, then you can know what you can get away with paying. And most of the time, what the collections agencies are buying, that bulk collateralized debt,
Mhm.
is for like anywhere from like 4 to like 8 cents on the dollar.
Yeah. Yeah.
It's somewhere around that range, but it's literally pennies on the dollar
Yeah.
is
It
what they're
is.
getting that debt from. And the hospital is willing to take that because to them, they're just like, it's going to cost us so much money in administration to try and continue to collect this at this point. So we'll take what we can get, and move on
Mm-hmm.
and recoup those costs off of actual, pass those costs on to actual paying customers,
The people
like
that
people
say,
who are insured and people, who are on Medicare, Medicaid.
mm,
Like it raises the cost for everybody else, those who don't pay. But, if you don't have insurance and you can't pay, like that's your situation. Like you don't have to feel bad about that.
no,
That's
yeah,
just where you are in life. And but yeah, once it gets to that collections agency, they will start making you offers. They'll say like for 75% of the cost of this debt, we can settle this today, or we
mm-hmm.
can get you on a payment plan. They'll also try the payment plan trick. You don't have to take that number
Yeah,
because they paid 6 cents on the dollar for that debt.
yeah,
So if you are stubborn and you are in a position where your credit being impacted for some period of time while you undergo this negotiation with the collections agency, if you're in a position where that is not devastating to you, which I understand is not everybody, but if you are in a tight enough financial spot where you wouldn't be considering filing medical bankruptcy here, that's a serious thing to evaluate whether you should do that. And
yeah,
I will typically only pay like 12 to 15, sometimes up as high as 20 cents on the dollar
mm-hmm.
on any medical debt that
Yeah,
I've had outstanding.
yeah,
And I will basically just let them. I'll play hardball with them. I'll let them know.
yeah,
I was like, listen, you're not going to get a dollar more than that off me.
yeah,
I can do this for years.
yeah.
And after 7 years, actually, a lot of people are not aware of this either. After 7 years, that cannot even hit your, they cannot even continue to ping your credit report.
Oh, really? I
Yeah,
didn't know
it
that.
drops off your credit report after seven
Huh.
years, which is the same. I believe that's the same amount of time that it takes for your credit to recover after a bankruptcy. However, bankruptcy is definitely worse.
Yeah,
Like bankruptcy comes with a whole host of other complications that you don't want to have to deal with necessarily.
yeah,
And medical bankruptcies are so common in this country, so I really think this information should be more widely available. Like
yeah,
I kind of would like to do like workshops on this. Providing people with some of this info, like especially like in the inner city here. I
mm-hmm.
just think that this information is so important to be spread around. It's a very nuanced system. Like it's like you're talking about dealing with healthcare, which is already complicated, and you're
Mm-hmm.
now talking about dealing with debt, which most people don't understand. You're
Mm-hmm.
talking about collections agencies. Like it's tiers of complication.
Yeah,
And I just by chance was very broke and very uninsured and had to figure this out,
yeah,
on my own. But
yeah. No one talks about it, and
yeah,
it's sad. The last time I looked into it, um, so medical bills in this country were the leading cause of personal bankruptcy.
yeah,
Not necessarily business, but
sure,
personal. And then there's a couple other numbers that went with that. So I believe one in five Americans are currently being chased by collection or in collections for a medical bill. Specifically, one specific example: one in four women with breast cancer who are undergoing treatment for breast cancer are being chased by collections agencies. And
wow,
that's just like when you think of it that way, like, of course, it's always embarrassing when you end up with something that you can't pay for. I mean, people don't talk about this, but people need to realize that this is widespread and it's very different than any other industry in our life. Anything else any other industry that service that you pay for, you get to see a
the price
price.
up
You
front,
see a
yeah,
price list, which that one thing that the Trump administration actually did was the transparency law.
yeah. They didn't get compliance on that though,
Oh, okay,
unfortunately. Like I don't know. I haven't actually looked into whether the Biden administration rescinded an overwhelming number of the Trump administration's executive orders. I don't know if that was one of the ones they rescinded. However, I do know that hospitals have not been complying with
really?
that.
Okay.
Yes.
Well, yeah. So I looked up my hospitals. It is on the website. It's difficult to find. They don't make it
Yeah.
easy,
Yeah.
but I did find that. But so yeah, in any other industry, you get to see the price up front, and then there's a contract. So you're signing up for a service that you're going to get, and you're willing to pay the price that's set. Healthcare should not be any different. And the people fall into this misconception that you get this surprise bill from a hospital for a service that you never signed up for and a price that you never even knew. The same applies. So a couple other things that I'll add on to what you were saying. When you go to the ER, that contract is often in the form of what's called consent to treat. So
Yeah.
they'll put this thing in front of you, and if you're conscious, they'll say, you have to sign this. They won't explain to you. It'll have this huge document of things that you're not going to read while you're sick. you don't have to sign that. You can actually write did not read, and that will never be legally binding.
Interesting.
Yeah, so that's one thing that's important because you're not going to sit there and read through that while you're in the ER.
Yeah, I'm pretty sure I've signed it every time.
Of course, because all they tell you is this is
Yeah.
consent to treat. But
Yeah.
but if you just scribble something and say did not read, they're not gonna not treat you. They're still gonna treat you.
Well,
They're probably not even gonna notice.
Yeah,
First
I
of
feel
all,
like they hand you a few other things too. Like they have you sign a few like more innocuous things, and then they hand you that consent form.
it's very mischievous the way they do it. But
Yeah,
so that's one thing. That's one way around being legally binded to it. Second of all, what Shabash was saying is when you do get that bill, you do not have to pay that. He explained it
yeah,
perfectly.
you don't have to pay it in full by any means. Like if you're paying more than 20 cents on the dollar on your on medical debt that has gone into collections, you're doing it wrong.
Mhm.
And like I know a lot of people like feel like, oh, it's the right thing to do. I should pay it. But this is a very broken system that we're
Mhm.
dealing with right now. And
Mhm.
there's not going to be incentive to fix it unless people, I mean, I actually think that this is sort of gaming the system if you do this, but you can do this with a lot of types of debt. And pretty much any type of debt except for student debt, you can do this with.
Yeah.
Student debt is the one that's on its own category.
Yeah.
But
And we'll have to touch on that.
yeah.
But yeah, I'll give one more plug for if anyone needs help. Restoringmedicine.org. They go into a lot of detail about how you can fight these bills that you're getting that are that aren't fair. I mean, truthfully, it's not something that the doctors want. It's not what the patient wants, and it should not be something that you feel that should be ruining your life. It should not be ruining your credit score. These are things that you have options to fight. So that is one other option that I will tell people, and it's something that I've kind of put into my practice because I don't know what when I'm sending a patient to the ER. I don't know how much that ambulance bill is going to cost. I don't know how much it's going to cost when they walk through the door. So I can't advocate on their behalf there. But what
Yeah.
I can do is give them the information that this is not something that should ruin your life. This is medical care, and they honestly do rack up the price so much that they make the money off the 90% of people that are going to pay it. So
Yep.
they don't care if.
Yeah, I truly feel for anybody that has been suckered in by that collections agency to like paying a debt amount to a hospital in full. Because like I said, that hospital is not going under
Mm-hmm.
without that money. They've already factored in, the hospital is not even getting any of that money. It's literally all going to the collections agency.
Oh yeah.
Whatever whatever portion would have been
Oh,
paid
yeah.
to the hospital had already been paid.
Yeah, they're getting a small portion of
Yeah.
it.
But I mean, since we talked about student debt, I did want to jump back to that
Yeah.
because that is one of the things that's tied to that chart that I'm going to put that chart back up again if you're watching on YouTube.
Mm-hmm.
It's from the Bureau of Labor Statistics on it's on the increase in costs in a number of categories, and it's just kind of showing like so what were some of these categories that we saw
So it's
there?
from 1998 to this only goes up to 2018, but
Yeah.
all these different industries, hospital services, college textbooks, college tuition, but then there's other common
so
things like
those are
cars.
the areas where the most drastic increase in prices is college textbooks, college tuition, and in medical services.
Mhm.
Areas where we benefited from and prices are down is TVs, cell phone service, computer software, toys.
Cars have been
Very
kind of normal.
marginally like cars, clothing, and home goods and furnishings. Like, listen, that stuff is great and all, but like I think most people would probably say like I'd take cheaper education and healthcare any
Oh, yeah.
day over all of that other stuff. Like the trade off has not been worth it, and also the quality has also declined on a lot of
Yeah.
that stuff. So it's yes, we get it cheaper, but it's also poorer quality.
Yeah. It's kind of
Whereas-
interesting how housing, food, and beverage is kind of right at the inflation line. So they're saying,
Well, those are core. Those are heavily weighted in the consumer price
Okay.
index. So yeah, so that it's like the inflation numbers reflect off of that stuff heavily.
Mhm.
But education cost and healthcare costs are not really factored into consumer price index because they're not regular expenses as part of that basket of commodities. But if you look at this chart though, which I'm gonna have up here on YouTube, you have like almost exact correlation from the late 80s to 2018 with tuition prices and with healthcare costs.
Mm-hmm.
And that correlation is uncanny because those are both areas where like payment is essentially guaranteed,
Mm-hmm.
right?
Yeah.
Um, Student loan debt is not expendable through bankruptcy.
Yeah.
You cannot discharge student loan debt through bankruptcy. And actually, the reason for that is your ilk. Actually, physicians back in the 70s and 80s began um, immediate filing bankruptcy the moment after they got done with medical school because they knew they could weather it and they could live without credit for
Yeah.
a few years and just making the
Oh,
money and just ditch all the debt immediately.
it crossed
So
my mind.
physicians were the primary offenders
Oh,
there
great.
that made the government pass legislation that made student debt not no longer dischargeable through bankruptcy.
I did
Um,
not know that.
yeah.
It honestly crossed my
Yeah.
mind. I thought
No,
about it. I was
of
like,
course. I mean, it's a lot of money. Like you're
mhm.
like that. You're talking a house.
Yep, yep.
There.
Just to put it into perspective, a U.S. med school costs about
It's
two
like
hundred
three to
fifty.
500,000. It's like
No, no, it's 250 to 300,000.
Yeah.
International schools, which is where I graduated from, is 400,000.
Oh, okay.
So,
Yeah.
yep,
Yeah.
it makes you think about bankruptcy, real.
Yeah, yeah. Especially before you've made like much of a dollar in your
Oh,
life,
yeah.
you're just like, man, that's
Yep.
yeah. But so that's why when you talk about the road to hell being paved with good intentions where regulation is concerned, yes, like the government guaranteed everyone's access to student loans. Every single person in this country can get a student loan, right?
Mhm.
Those are federally guaranteed. However, like we said, trade off, they're not dischargeable with
Mhm.
bankruptcy. So, what incentive do schools have to lower prices then? None.
Yeah.
Absolutely none.
Yeah, it's a business.
Because if they raise prices, especially if they all kind of, they don't even necessarily have to collude. They just kind of have to watch each other, and this process has to move in aggregate together. So sort of right,
Yeah.
like one school like Harvard raises their tuition a little bit, and Yale's like ours is still like $1,000 less than that. Maybe
Yeah.
next year we raise ours and match Harvard's, or maybe we go a little bit further even.
Mhm.
It doesn't matter. Like the prestige of the school doesn't even matter because school has become, higher education, university has become such an essential component for entering the information economy, which is what most people want to do. Most young
Mhm.
people would rather work in an office than in a factory floor or
Mhm.
in a lot of other environments. So they're like, I have to go to college if I
Mhm.
want to get a job that will pay me enough to be able to afford a house and live comfortably in high cost of living city that I live in. So yeah, people view college as like not even optional,
Mhm.
and I can sympathize with that. It's what they're told to do, and they're just doing what they're told to
Mhm.
do. But that cost, I believe, is also directly passing on to healthcare. Like you said,
Mm.
that $250 to $400,000 cost to train a physician is absurd when
Mhm.
you consider the fact that you can train a physician in parts of Europe, in Asia for like
Yeah.
$40,000, like if that,
Mhm.
So of course people are going to attain those degrees, and this is happening actually all over America. Is people who are attaining degrees abroad, not even just in the
Yep.
healthcare sector. This is happening elsewhere as well. People will obtain an engineering degree abroad, for example, and then they'll come to the United States. They'll pass some equivalency tests if their industry requires it, even,
Mhm.
and then boom, they
Yep.
are now they're not going to demand as high a salary as an American
Yeah.
worker would, because the American workers all spent 100K on their
Yeah.
education. The foreign worker spent 20,000
Yeah.
or spent nothing. I met some very savvy Uber drivers
Yeah.
in my day. This guy that comes to mind, okay, he came from somewhere in West Africa. Very, very smart guy. Took his family to France. His wife and kids are still in France, being educated at the French taxpayers' dime. He's here working as an Uber driver while also taking like some IT certifications and like getting himself positioned to be able to move his family here after the French taxpayer have thoroughly paid for the education,
Yeah.
and they're also paying for his wife's cost of living because she is has all these dependents and has no husband who lives
Yep.
in France with
Yeah.
her. So the French taxpayer is paying for their rent and
It's a pretty good
education and all
gig.
this stuff. Yeah, so like in his case, he's totally gaming the system. He's getting free college education for his kids.
Yeah.
Getting his wife taken care of by the French government, and he's over here like planning his next move.
Yeah.
And like a really hardworking dude. Like I gave him a bunch of advice on like how best to navigate like the IT
Yeah.
space, but
And at the end of the day, they're gonna end up right back where the same place as American graduates.
exactly without all of that debt
Yeah.
hanging over their heads. So yeah, it's
So like, where does I mean, I guess we've been talking a lot about healthcare. Like, where's all that money dumping into? Because the professors aren't making millions. Like,
yeah. I mean, we kind of touched on this actually in the last episode. I think
yeah.
we touched on if I'm gonna pull up this chart if I can find it on YouTube. The ratio of administrators is really where this
Mm-hmm.
has gone.
Yeah.
The ratio of administrators to educators. So you see the same problem in healthcare with
Yeah.
the ratio of administrators to providers and physicians.
Mm.
It's like there's really, in my opinion, there's just a lot of people with jobs that don't need to exist, like people that are essentially wastes of space, and I don't know how they've convinced their jobs to even exist, like how like who has advocated for or lobbied for these jobs to even
Yeah.
exist. I'm not
Oh,
fully
and of
sure.
of course, they're not going to be the one that says, "I don't need to be here. I don't need to be employed."
Oh, of course. I
Yeah.
mean, everybody's gonna fight.
Yeah.
Administrators kind of stand together, and this is like the same problem we see in government, right? Except the difference is, at least in the private sector, if you're grossly incompetent or you cross certain lines, you will be fired.
Mm.
But like government, like you're virtually, you're not even getting fired for
Mm-hmm.
like some really heinous and absurd behavior sometimes. But yeah, like you gotta ask yourself, like when you hear about what some people's jobs are, you're like, what you make 60, 70 grand a year to do what now? Like
It's crazy.
yeah, yeah. I mean, the fact that every university and I mean, now increasingly, private corporations as well has like a diversity, equity, and inclusion office. Like not even just one dedicated personnel to that. Like they've got a diversity, equity, and inclusion office.
Yeah.
What do those people do all day? Tell
Yeah.
me, like push forward initiatives. Like all it takes is one person to compile a report and say like, hey, we should probably hire more of this minority
Yeah.
group. Like I just don't see how you need to hire
Yeah.
an entire staff to do that. And
Yeah. Well, I mean, it looks good for public relations. I
it
mean,
does. And actually, now that I'm glad you said that because it's not just public relations now. It's something. This is a topic that Glenn and I have discussed at length. It's you have ESG, which is environmental social governance. It's a new standard that's been pushed forth by some of the largest private investment firms in the United States. In particular, actually, BlackRock, the largest investment firm in the United States, manages trillions of dollars in assets.
hmm.
BlackRock CEO Larry Fink, he has been a major advocate of ESG. What ESG essentially is they are assigning an arbitrary score to companies based on how well they perform on like I said, arbitrary metrics and on environmentalism, on
Hmm.
social, and then on social governance. Which you ask yourself, like, how are you quantifying, like, how good a company scores on social
Yeah.
governance? Well, they'll say like, how diverse is this company? Like, what is the ratio of like male to female executives?
Hmm.
Ironically, go look at BlackRock's board, and
Yeah. I'm sure.
yeah. It's like that, but um, so it's really funny because Tesla, um, you know, the first like major EV maker in the world and like major innovators in that space, they have a very poor ESG
Hmm.
score, and Ford and GM have better ESG scores than Tesla does.
Interesting.
And you just got to look at that and laugh and be like,
Yeah.
what does this even mean? But it actually matters to these companies. Companies that are this large, their ESG scores is assessed by banks when they go seek financing deals. So when they try to get money, the banks are like, oh, actually, we can't offer you that amount of money on those terms because your ESG score is too low. And
Wow.
that's concerning to us.
Is it
So,
is
yeah,
it something that the government has mandated?
not at
Okay.
all. This is entirely the private sector doing this.
Wow.
And it is partially in response to certain government regulation, especially in the EU. The EU has a lot more regulation in some of these spaces. In digital privacy, they have GDPR. In food agricultural safety, they have higher standards than the United States does.
Hmm.
So in sort of like I do see some value to a score like this potentially, but the way it's been administered and the way the actors that are pushing this forward, I don't believe their intentions are good.
Yeah.
I think it's mostly about control for them.
That's crazy.
Yeah.
I didn't know that.
Yeah, so it's not just reputational. A big reason a lot of these private companies are spending
So
money on, various things on environmental, like I look, believe me, I'm very pro environment. Okay, like so
Yeah,
I'm
yeah,
not knocking people doing good things for the environment, but a lot of this is just really moral posturing, right? It's not
yeah.
actually doing anything good. Even the carbon credits,
Mm,
carbon taxes, carbon credits have been so poorly administered that I remember when it was first implemented in I think it must have been in the UK, um, ArcelorMittal, okay,
mm,
massive steel company owned by an Indian guy actually.
mm.
They, if I recall correctly, they did not even have to change anything because of the way the carbon credits were structured. This was cap and trade policies. So what the government was coming in and saying, this is where your emissions should be. This is where we would want to see them at.
Okay.
Anything if you're above that, you need to reduce your carbon emissions. If you're below that, though, you have all these extra permits that you can sell to other companies that are in violation of that while they get their stuff in order. So, but the thresholds were set so high that a ton of these companies literally had to change nothing, and they just had free, permits to sell to other companies that were smaller companies that may have been in violation
Mm,
in some way. And like so, a ton of these giants, and I remember ArcelorMittal Steel being one of those companies that was just like, okay, we're gonna change nothing, do nothing better for the environment, but we're gonna make more money for
yeah, of
free
course.
as a result of this environmental policy.
Jeez. I mean, it's another example of the dangers of putting numbers on everything. I mean, you can't just quantify these kind of things, and
Yeah, this does tie into our conversation
yeah,
on
yeah,
on metrics and bureaucrats love metrics, man. They really
yeah.
do, and they're the reason why we're in this situation to some degree, and there's so many of them. And
Do you see it going in like the same direction as where it is now, or is it gonna swing the pendulum gonna swing the opposite direction?
I don't know how you reverse this because these people are so deeply entrenched, and they have more political influence within
Mm,
their organizations than the actual people that are doing the work, right? Like an administrator has more say on policy than you do as a physician,
sure.
even though as a physician you are like a high tier, like highly compensated, respected employee within a hospital. But certain like low level administrators have more influence than you do. It's the same thing with HR in a
Mm.
company, right? HR wields, unnatural levels
Everyone's
of
scared of
influence and
HR.
control.
Yeah,
Everyone fears them. Yeah, despite the fact that these are people that, like even if you make 5 times as much money as that HR person,
yeah,
you're not messing with them.
yeah.
Um,
Toby from The Office.
yeah, yeah,
That's interesting.
yeah, I don't see a reversal in that.
Mm,
You did see a lot of under the Trump administration, they cut more regulations than any presidential administration, I
mm,
think, in history.
mm,
Like they were just cutting regulations left and right. And at one point, they had an executive order in place that said if you wanted to add a new regulation, and this was so broad, I don't know how this was actually administered, but they said if you wanted to add a new regulation, you had to cut two old out of date ones, which was probably good in a lot of ways, may have been bad, and like it happened on such a broad scale over such a fast period of time over 4 years of
yeah,
the Trump administration that I think it remains to be seen like how much of it was good, how much of it was bad. Somebody would have to do like a real extensive study on that.
yeah,
I'm sure there was areas where it was good and there was areas where it was bad,
yeah,
but
yeah.
that's one of those things. I don't think that bureaucrats and administrators don't ever cut themselves out of a job,
Mm.
and they don't solve problems either because if they solve problems, then they're effectively cutting
Out of
themselves
the
out of a
job.
job.
Yeah.
Yeah,
Jeez. Mm.
yeah. Well, I'm glad. I think we were able to cover
Yeah.
pretty much everything
Yeah. I
that
think.
we really wanted to touch on, and yeah,
Well, okay. If we have time, the one other thing,
yeah,
and it kind of ties in with something else we were just discussing before we started recording. But
sure,
I as a resident, like I didn't really have a good grasp on, during the pandemic shutdown, um, most of the money that the hospital brings in is definitely from specialists, from procedures, and a lot of that got shut down during the pandemic.
so what I was talking about last
Yeah,
time,
something
yeah,
you asked me, and I didn't know how to answer that question. And you kind of you asked me how did hospitals bounce back from that? Because really, when it comes down to it, me as like a general practitioner is not the one that's going to be bringing the money in for the hospital. We are maybe cutting even for them.
yeah,
The money that they're getting is really from people that have to go to the cath lab to get a stent, people that go to get their gallbladder taken out, people that want to go for a what's it called, knee replacement.
Yeah.
A lot of those are elective.
Yeah.
And during the pandemic, that got shut down, and we did see that, and rightfully so. We didn't know what was going on. We didn't know the risks and what was worth it. So we just kind of shut down business for that. And you did ask me last time, how did the hospitals kind of compensate for that?
Yeah, because that's what I had read, that
Yeah,
they lost a ton of revenue.
yeah, and I had to think about it. I mean, it's strange because you do have to, as a even a non-for-profit or a for-profit hospital has to have some way of rebounding from basically 2 years of lost income there. Um, and kind of came to me later. I noticed that after the pandemic and after the shutdowns, once things started going back to business, one of the big ones that I would assume had to do with making up for lost income was nursing shortages. So
Mm.
they were cutting the staffing on the floor. A lot of nurses left. A lot of nurses just weren't being staffed, and what that ended up doing was it overworked the nurses that were there. So to the point where, I mean, I can vouch that there were times where I was concerned for a patient, certain patients being taken care of properly because we were so short staffed, and nurses were just being worked to the bone. I mean, you could tell like they were just tired. Nurses that had been doing this for decades, all of a sudden were just exhausted. And I think that's kind of, we're seeing the repercussions of that now. A lot of nurses have left. They've retired. They've gone on, and there's lots, and all that's done is cause more of a strain on that side of it. There's this whole other side of the nursing industry that I don't understand, but
Well, that's why you were hearing a few months back about how much money travel nurses were
yeah,
getting. They were getting paid like doctors
that's what I was saying. I
because
don't understand that.
certain areas were so hit by the level of retirement, by people burning out and
Yeah,
leaving, that they were like, we'll pay whatever we have to because we need to keep this place
yeah.
staffed.
And again, like I'm not very business minded, so to me it just doesn't make sense. Like they are paying them. I've heard upwards of $200 an hour for travel nurses,
Yeah.
and a lot of nurse practitioners who again are trained to basically be the physician, are leaving their jobs to go back to be nurses or traveling nurses because they will make more doing that, which
Yeah.
is just crazy to me. I mean, why would you? And there's downsides to that too. I mean, they're great nurses, but if you're going to a new hospital system with a new EMR, you don't even know your way around. You don't know where we keep our supplies. How is that best for the patient? How is that best for anyone?
Sure, you're like a consultant at that point. You have
Right.
less skin in the game.
Yeah. And why? And to me, it's just business wise, it doesn't make sense. Why would we not just pay our nurses more and let's keep it staffed properly? But maybe this is all repercussions.
Well, what you're saying is a rational proposition, and this is one of the problems with private equity and money guys having taken over so many of these industries,
Mm-hmm.
is that they have no business really operating. I've seen the same thing in manufacturing, and what you're describing is what's happening in healthcare right now as well. These are money guys that are looking at the purely at the numbers, and they're making these poor assessments that may seem wise from a business standpoint, but it doesn't express a broader understanding of the circumstances.
Mm-hmm.
Like you're saying, you're on the inside, so you're intimately familiar with what happens, and you actually talk to these people. You
Mm-hmm.
talk to nurses,
Mm-hmm.
right? Not one of these private equity guys or their consultants probably talks to a single nurse.
Mm-hmm.
They're looking at numbers, they're looking at charts, they are speaking to a few administrators and bureaucrats, and they're making their assessment on how they should conduct policy.
Mm-hmm.
And yeah, it's a very messy way to conduct policy.
It's crazy.
Yeah.
And another thing that like I guess I haven't had the freedom to speak up in regards to the nursing shortage is it was kind of interesting, and again this might be controversial, but when the vaccine came out, as healthcare workers we're kind of expected to receive or to accept certain
Yeah, you're
preventative
talking about the
things.
mandates.
Yeah, yeah.
Yeah.
So, as a physician, I accept those extra responsibilities.
Sure.
A lot of the nurses were very hesitant, and rightfully so. I mean, we knew very little about this, and we knew very little about the effects and the efficacy. So a lot of the nurses were kind of, is this really worth it for this career, for something that I'm already getting worked down and
Yeah.
exhausted for, and I can empathize with that. So we actually lost a lot of nurses for that reason too. So
Really.
on top of them being short staffed, they were also being forced into something that they didn't understand or didn't agree with. And at least in our hospital, I mean, I think most of Ohio, it came down to a deadline, and they said if you don't want to get it, you'll be fired.
Yeah.
And there were nurses, I mean, good nurses that left their position for that. And it was very interesting because probably about less than a month after that was when kind of the virus had kind of mutated and a different variant had come around, and all of a sudden the administration was changing their rules. They were saying, oh, instead of 10 days off, maybe 5 days. And then
Yeah.
they even went less because they were so short staffed. It got to a point where they were actually telling the hospital staff, if you test positive for COVID, even if you have symptoms, as long as you're vaccinated, come back to work.
Yeah.
And so we went from
Knowing full well that you were still contagious during
knowing
that
that,
time
yeah.
period. Yeah.
So, and to me, like, again, it's controversial because as a healthcare worker, should you be held at a different standard of expectation?
Sure.
Sure.
Yeah.
But if you're going to go so far to say that we can't risk our patients' safety because if they're not vaccinated, there's a potential that they could get the infection and potentially pass it on. And then all of a sudden, a month later, you're going back and saying, oh, we're so short staffed, just come back to work. Like,
Yeah.
that to me was just mind blowing. And of course, it's very difficult to bring these things up in the medical field because it was so new. It was so many things were going on, and but to me that made no sense
Yeah.
logistically.
I kind of understand the plight of those nurses that didn't want to adhere to the policy because you went from being, hailed as like the heroes of the pandemic, as
Hmm.
frontline workers for all this time, to being tossed in the trash essentially and saying like, hey, if you don't like get with the program, and you were, you were getting labeled as an anti-vaxxer, for
Hmm.
example, for not wanting to get something that was still under EUA,
Hmm.
still, a lot of the documentation and studies, the clinical trial data still wasn't released yet.
Yeah.
It's now being released, and they were actually pushing to wait like 70 something years to release the clinical trial data. They were forced by a judge to release it faster, and I think they're
Hmm.
releasing it at like I think actually by this fall, all of the Pfizer clinical trial data will be released. Somebody's,
Interesting.
I mean, I hope there are people already poring over that data, but these are people that you have no indication to accuse them of being anti-vax.
Hmm.
They have a number of vaccines. They had to be vaccinated for a lot of things to ever get a job at the hospital,
Yeah.
I presume.
Yeah.
And yeah, just the other concerning factor is that many of them have, from having worked in the hospitals during the pandemic, got COVID
Yep.
and had some level of natural immunity, which we now know,
Hmm.
studies indicate is more robust than
Yeah.
protection from the vaccines,
Yeah.
even the higher efficacy vaccines.
Yeah. And I'm
So
sure I'm sure everyone's
yeah,
sick of hearing about this. I mean,
yeah, yeah.
we're supposed to be talking
COVID has
about.
been beat to death at this
Yeah,
point. Let's
but
yeah,
I think I would. I mean, it would benefit for us to at least have the discussion that things do change,
yeah.
and from when it first started, when I was seeing the amount of hospitalizations, and I was seeing sick people. I was all on board for it. I was, it was kind of a grasp of desperation of whatever, I'm willing to accept the risks. Let's
Even
just.
if it's only of marginal benefit, you're
Right,
like,
right.
yeah,
I mean, just
yeah.
just like the flu shot, and and then it kind of evolved, and I think that we kind of failed because we tend to get so set in these polarizing positions, like you said, being labeled as an anti-vaxxer. Well, what if the vaccine changes or the virus changes, which it does?
Hmm.
People were so polarized and so set in their ways, especially in the medical field, that they were unwilling to kind of evolve with the evolving nature of this beast. And that's something that I think people need to do more, especially in medicine, because we've that's an medicine in general has always been like that. We evolve with it. We learn to change our mindset. And this is probably, I mean, at least in the short time that I've been in medicine, like I feel like that didn't happen. People were just so set in labels, and I'm on this side and you're on this side, and it's very dangerous, especially when that gets brought into uh, these, something like healthcare.
Yeah, I hope that we're able to move forward from this because
Yeah.
we talked a little bit last time about how much damage to credibility had been done
Mm-hmm.
for the industry as a whole, and you know, two institutions that lost the most credibility. Like this is not my opinion. This is based off statistics.
Mm-hmm.
I don't recall which who conducted this study, but it was a reputable polling institute. Conducted studies on trust levels on the medical establishment and obviously on the government.
Mm-hmm.
Um, Steep decline in those areas. In the wake of this pandemic and just how things were handled, people were extremely displeased with it all around.
CDC.
Yeah, yeah. I mean, I think it might have been the question might have been phrased more broad, but yeah, I'm sure trust in the CDC, the NIAID, the
Yeah.
NIH, all of these
Yeah.
institutions has been drastically reduced, and
Mm-hmm.
that's not helpful.
Yeah.
If you like, I'm somebody that stands in opposition to institutions like this at times, but I don't believe that every single institution we have should be torn down.
Right.
Like
Right.
they have value, but they should only have value if the people within them, the people leading them especially, are credible and honest.
Mm-hmm.
And that's not something that we've seen.
Mm-hmm.
A really interesting thing. Kentucky Congressman Thomas Massey. Um, he is I believe he has a degree in some sort of biological engineering from MIT. Like, brilliant guy.
Mm-hmm.
Built his own. He has an entire like off grid solar system. Grows a ton of his own crops. Like wired it up to a Tesla Model S battery that he like got off a totaled Tesla. Like crazy guy, but he's a really smart guy. He recorded these calls. Like I can't remember who he spoke about it on somebody's show, but contacted the CDC about like what he gave them the benefit of the doubt and said, oh, like I've noticed an error in terms of like how you're phrasing a statement
Mm-hmm.
related to COVID infection,
Right.
and they were like, oh wow, like you were so glad you caught this error for us, and he was like, oh, so you're gonna correct it, right? Basically, I'm paraphrasing like what,
Yeah.
what
Yeah.
was happening, and they were like, yeah, we'll correct that, and gets back to them. He's like, hey, I noticed this error that I caught still hasn't been changed, and they're like, oh well, actually, like we don't want to give people the perception that like this is okay for them to do, and like
Mm.
I don't like off the top of my head I don't recall like the
Yeah.
specific
Yeah.
thing, but it was just like that's so bad when you have like an agency that's willing to say that to a sitting congressman who's like a very highly educated guy, a guy
Mm.
who has a platform who
Mm.
can call you out on this,
Yeah.
and you're still gonna say like, oh well, sorry, actually the bureaucrats have decided that like that line needs to stay
Yeah. That's sad.
phrased that way.
Yeah.
But yeah, I mean, I'm glad we at least did this talk at the
Yeah.
tail end of the show because, like you
Yeah.
said, like people are sick to death about hearing
Yeah.
about
Yeah.
this. I haven't even talked about this,
I
like
know.
about the
Well,
pandemic in like ages.
I
But
just I think it's
yeah.
entertaining because it's something that me and you have disagreed on within the last year, I can
Oh,
say.
we had spirited debate about
Yeah.
this for months. Like,
Yeah.
I mean, how many studies did we send each
Oh
other back
yeah.
and forth?
Yeah,
And
but
yeah,
that's I mean, ultimately that's the goal of this kind of conversation is it should be an open conversation to the point where you're both people are willing to learn and you can learn from each other instead of just choosing a side and saying this is the right way. I mean, that's not how medicine, that's not how anything in this in our life should be. It should be about open debate and open conversation and learning.
very well said. And I don't know if you knew this already, but that's like very much like like Glenn and I have had like a little spiel on like that's what
Yeah.
this show is
Yeah.
about. And yeah, I mean,
That's
I'm
cool.
looking forward to like being able to dive into more subjects with, and I'm glad we were able to make it again and we were able to have like a continuation of our
Yeah.
last conversation.
I
So
appreciate it.
yeah, thanks for coming on,
It's
man.
always a good time. Thank
Appreciate
you.
it. Yeah.
See ya.